Welcome, everyone, to the second installment of the Access podcast with Steve Fields from Progress Foundation. Now having a long conversation that started with deinstitutionalization and is up to modern day and modern day policy, and what is happening in these massive policy shifts in California. Steve, would you like to briefly reintroduce yourself for those that didn't watch episode 1 of the podcast?
Sure. I'm Steve Fields, Executive Director of Progress Foundation. I've been with the organization since its founding, right in the very days of deinstitutionalization in 1969, and I'm still there as the Executive Director. We're a nonprofit 501c3 organization that for the last 55 years has contracted with counties to develop community-based 24-hour and supported housing environments that can challenge the necessity to institutionalize individuals in either hospitals or IMDs or in jail. So our organization goal is to find a community-based analog for every institutional solution we have that allows people, for the most part, to live in the community while they guide their own treatment, receive services, and have an opportunity to stay in the community rather than be extruded into some foreign environment where they're supposed to get better. So that's the Progress Foundation model, and we keep learning and improving, I hope, and trying to spread the idea that community-based treatment works if we provide it. But sometimes it feels a little bit like we're moving in the other direction.
Yeah, that's what
involuntary treatment is supposedly the solution when there are no places for people to go to get better, but they are being remanded into treatment, and that's an ominous trend.
Yeah, I would like to touch on modern day in California, what's happening now. But before we go there, I would like to flesh out a little bit more. I find that the general public doesn't have any idea what our community means when we talk about recovery, or, as you said, interrupting chronicity, right? So there's this idea that serious mental illness is always sort of, stuck speeding at 60 miles an hour and no one gets better, and it never goes down to 25 miles per hour. It is chronic. It is stationary. And I think for those of us that have these illnesses, we know damn well that's not true, right? Mm-hmm. We know that even when someone has written you off as the hopeless case after 10 years of really being burdened, that can fundamentally change. And that's my own lived experience. So, and I've seen it with other folks too. It can also go the other direction, right? You can, just because these illnesses wax and wane independently of, our medical interventions, and they are interwoven with, the Congress of the rest of our lives. So, this idea that things are static is really untrue. But one of the things that I wanted to ask you about was, okay, what was the impact of institutionalization to the folks that you were receiving as they were coming out, particularly from Napa State Hospital after decades of institutionalization? What was the impact to them? And why is it that you believe so much in community-based resources that are recovery-oriented? If you could just, if you could give folks an idea of, hey, there's something else, and it's a much better thing.
Mm-hmm. Well, I think the most sort of developing awareness I had by spending so many hours of my life in the conversations with people who had the 6 original residents of Progress House probably had over 100 years among them of institutional treatment in and out of hospitals. And so, when you're sitting in a living room with people and trying to get to know them, you start to learn, you hear the arc of their story. And it was so different from how I heard them talked about literally when I was in the hospital trying to get a referral to get them into Progress House. It was so narrow and so commonly describing their diagnosis before they described their life. It was just so I would learn this process. And there were two things that just struck me that probably kept me working at Progress House, because I figured, that if we don't find a way to address this, this system isn't ever going to help anybody. And the most significant one to me was how little hope they had about a future. They did not come into Progress House after this time talking about their dreams or what they wanted to do. They were just surviving in a way day to day with the effects of being diagnosed mentally ill and having symptomatology stuff that perplexed them. And I would bring all this faux enthusiasm to the conversation because I thought, well, that I could at least be like upbeat, and and those were sometimes very interesting conversations, but there was this sense that one of the primary impacts of treatment after all this time, 3 months in the hospital, 2 months in the hospital, all the medications, everything else, was a couple of messages. Take your medications. A diabetic is a diabetic for the rest of their life. And if they take their insulin, they're fine. You're going to be schizophrenic the rest of your life. Take your medications. And those were the boundaries of expectations that were conveyed to them in this process. So when I would try to sometimes very naively talk about where they might want to go or what were they hoping to do, it often elicited a blank stare, like, I'm not going to. My friends all went to college. My friends all graduated. They've got jobs. I don't even know them anymore. The only people I know are the people I meet at day treatment who are in the same cycle I'm in. So what occurred to me was, I'll tell you a little side story about another lesson I learned. There are the milestones about when I started, when I was awakening to what the system was really like in the way it weighted down on the people who were in it for treatment. As I started reading journal articles in the mid-'70s about things, and then I got a chance to be on President Carter's a task force for President Carter's commission, and they sent a whole bunch of stuff to me. So this would have been like 76, 77. And I'm reading these journal articles, and they would have an article like, medication management with yak patients, because in journals you get acronyms. Maybe the worst contribution of the mental health system was all the acronyms that they've created. We are an acronym addicted system. If we're going to put up a new program, first we have to think of a cool acronym and then fit the words to it, rather than think of a good program. Anyway, so I'm looking at these articles and you'd see, okay, or treating yaks in a day treatment environment. And so the YAC, the yaks, which is how individuals were now categorized, refer to young adult chronics. So I was an English major. I believe in the English language being important. And I'm saying you can't be young and chronic at the same time. That's a prognosis. That's not a description. It's not a diagnosis. But if you have a system that, without even having the humility to look at their own language, the own prejudices they brought, that the client, patient, whoever feels immediately, you're calling somebody young already chronic. Well, why would you do rehabilitation investments in your system? Why would you have vocational discussions with your patients when they're already a young adult chronic? That's a contradiction. But no one noticed it. Nobody seemed to say, this is wrong. We got to fix this. And it, in a small way, it was a doorway into seeing how the system believes in the hopelessness model that is predominantly laid upon people who are come into the system.
I would just really like to say amen to that from my personal lived experience. I have found, having experienced psychosis, having been around, psychosis for such a long time, I find that one of the most unhelpful things the mental health system does is catastrophize that, right? The hopelessness is not something that you necessarily inherently experience as a result of symptomology of serious mental illness. The hopelessness is a reflection of what other people believe about you and how they will limit you to their own vision, to their vision for your future. And one of the things that, we're so big on here is peer support. And one of the reasons is that I think the most, I have experienced with other folks exactly what you're talking about, the blank stare, where we have deadened someone's life so much they don't even dream anymore. And I will say that one of the things that was most revolutionary and helpful for me from a peer support worker, my friend Rachel, who really changed the course of my life was, I was like, look, I am an absolute wreck. Everything it's all just crumbled and fallen over a long period of time. And she was completely unfazed. She was like, oh, you're going to be fine. She's like, no, I absolutely know that you are going to be fine. Just this, it wasn't, as you said, even faux enthusiasm. It was just her experience. And just the bringing down the temperature in the room, not engaging in this catastrophizing, especially around psychosis. Do you know how many things cause psychosis? Do you know how many times, you think it's just mental illness? Like, I could rattle off probably 50 things, right? This is not an unusual part of the human experience, the biological experience, the biological functioning. But in this one area, we catastrophize the hell out of it as a system, and then we put that onto people and tell them, get out of bed. Well, why should they? When every other message you're giving them and every other opportunity and every other quote unquote support you're giving them is that their lives are going to be miserable and hopeless. And, that to me is just, I have seen both the damage that has done to clients, but also as a peer provider. And honestly, like, we do this, we got like a network, right? Like, if one of our friends is experiencing a mental health crisis, especially for the first time, it's like, oh, well, come talk to us, just informally. And I have seen how, the ability to project not only hope, but a confidence that this doesn't have to be the worst news you ever got in your life. Look at all of us. We're all fine. And we weren't at one point. And you can be too. And I think, that's one of the ironies, I don't know, maybe that's not the right word, but one of the things that I've really noticed, as an observer of the way that the sane think about the insane, is that even if you look at media, you look at movies, right? One Flew Over the Cuckoo's Nest, or I'm thinking of some scenes from the very, popular TV show 10 years ago, Homeland, right? The thing that is so horrible about mental illness is it is never a portrayal of the person's internal experience. It is a portrayal of what sane people will do to you if you are insane. It is a portrayal of being dragged down hallways screaming. It is a portrayal of straitjackets. It is a portrayal of being thrown and locked in barren rooms. It is a portrayal of the abuse of the creation of an unlimited authority of one human being over another, and the inherent abuse of that. It's an inherently abusive, arrangement. And so, I'm just really feeling what you're saying there, that, one of the effects of institutionalization was actually to instill that hopelessness, and that you have to, that is one of the things that you have to undo to even get folks to have, I think, to get folks to be engaged in their own lives again.
Yeah. Yeah. And to this day, the rhetoric has changed. There was some point at which I guess client-centered became a way that a system that's staying 3 points removed from humanity decides to describe something. So now it's in every brochure. Even institutions have client-centered institutions because you have to say that. And this lack of self-examination, which I've just felt was necessary for me. I mean, progress has, gone through shifts it had to make, things I thought could work that weren't necessarily going to work. But overall, a system that votes on a mental illness, like being gay, or should take a big dose of humility. I mean, it just always struck me that when I would want to piss people off, who saying, you're the only medical profession that votes on your diseases in a way. In 1971, if you were a gay man, you were mentally ill. You were in the DSM, whatever. You
Absolutely.
could bill.
And it wasn't just, I will just interrupt you and say it wasn't just till 1971.
Yeah.
Try 5 years ago, right? The total lack of self-reflection around what, yes, the American Psychiatric Institution, I think, is who makes the DSM, and as you say, votes on illnesses, but also the complete lack of ever taking any accountability that social and political and cultural biases that have been hopefully eschewed, deeply influenced what was viewed as illness, because there are no objective tests. There is no known mechanism. We actually don't know, quite literally don't know much, if anything,
right,
about serious mental illness. And so I think, another thing that I think we really vibe on is, that if you see somebody in this system that lacks humility, that's a serious problem.
And that takes constant vigilance to not lose your humility, when you have it. I mean, it's absurd to, and the best clinicians I've met, and ranging, and I met some amazing clinicians who operate in that same, complicated environment we operate, understand that sense of uncertainty and not knowing everything. But, to just raise with some of them that, the APA voted on a mental illness, and they had a caucus that was able to get the votes. And in a close vote in your environment, you decided to drop a disease, a manifestation of the disease. So something more is going on here than science. So drop the white coats in the science and maybe open up to learning some stuff about it. And it's been, that kind of give and take dynamic. I mean, I say a lot now as I look back on the Progress Foundation experience over the time, is how often there were key traditional clinicians who align themselves with our vision and our point of view that were why they were able to keep going forward. Our crisis residential program was such a gamble. Nobody had done one like this in 1978. And I don't know, I thought I was crazy myself that I would really try this, but it looked like it was the next thing necessary. And it was having a psychiatrist who would go speak to the other psychiatrists on behalf of this idea, because nobody would listen to me when they found out I didn't have a degree or anything. So that paved the way for this. So finding all of these opportunities to align with folks, going all the way back to the Soteria project, which, if folks are curious about what possibilities were developing in the environment back in 1969 and 70, like a lot of things back then, before things hardened into a more politically polarized reality, more conservatism, more fear of liability, all that stuff. There's a project in San Jose that was funded by the NIMH to do a controlled study of for Santa Clara County, of a crisis residential program that was medication free. There was no medications used. It was sponsored by the NIMH.
That would
It
never
was
happen now.
oh, I know. It was a blind study referral out of the emergency room, Santa Clara County emergency room, where they randomly assigned a person who would have been hospitalized to an inpatient unit or to Soteria House, a residential program in the community. And it was a research study that people had talked to me about when I first started working, because I was looking for who are the crazy people working in mental health because I need to talk to somebody about, so I recommend that people look it up. And I learned a lot of lessons from that. And in a way, the Progress Foundation, the impetus for me to stick around and do this, that as looking for something useful or exciting to do, was the Soteria project, and going down and seeing that site and seeing, what in the days of, R.D. Lang and Thomas Saz in his early part of his career, what was possible. But it opened up like a brief ray of light, and then by 73, it all started to shut down, because then the conservatism set back in, and we weren't going to be able to do any of those kinds of things. But it opened up the possibility where, sort of my goal early on was to try and find a version of that project in the public system, not medication free, because we had so many clients by that time who had been on meds for a while and a long time. It wasn't responsible, but medication skeptical. To look at the levels, and the first solution was medications. And there have been those kinds of efforts to sort of define what parts of a system of care would start to look like if they had said in 1970, we're going to do a huge project. We're going to define what a community mental health system has to have in place, what its goals are, and how it works. And we're going to do a commission on it. We're going to set it up. So that never happened. That never emerged in one piece. I mean, the closest to it in a weird way, Claire, was a piece of legislation a colleague and I wrote actually in 1978. Just in a quick California history story, when Jerry Brown was elected governor the first time in the late 70s, he announced at one point that 1978 was going to be the year of mental health in California.
Oh, that's fascinating. I didn't know that.
Yeah, and again, what past is prologue,
Right.
And some cynics said it's because he was running for president, and Jimmy Carter had cornered the presidential role of mental health with his commission, and that California, everyone felt, was failing in many ways in its mental health system. So he said, to hell with that, we're going to pour he put $80 million in. Now that's a rounding error. In 78, that was a big investment, right? So a guy who should get recognition for how much he did for mental health in California in terms of fighting for change, Assemblyman for Berkeley, Tom Bates, had been newly elected to the assembly, and he wanted to specialize in something, and he decided mental health would be his area. So Tom Bates had done hearings around what are we going to do, and I had spoken at one of those hearings. I don't know how I got on the agenda. It's like,
I just crash them. I just show up, grab the mic.
I crashed the party, and he was from my district. I live in Berkeley, so maybe that's why he was being. So I did a testimony thing on how we need a system of alternative treatment environments in the community as part of this overall vision of community mental health system. So he called me the next day and said, come in, I want to do a piece of legislation. And I said, okay, I'm ready to go. I've never done this before. Well, what do you want to do? And he said, well, I heard your testimony. We want to fund more board and care homes all over the state. And I looked at Tom and I said, Assemblyman Bates, is that what you thought I said in that testimony? Because I don't think I said that. Board and care is part of the problem. That's the maintenance and the system. That's not a recovery. So he said, well, what did you mean? So I went off with this colleague of mine. I wrote a bill and called the Community Residential Treatment System. And it outlined in 1978 the elements of this process of getting away from hospitals toward community living. There were and I wrote this system of care thing. what I'm proudest of, Claire, the reason I'm telling you this, I don't think it, what
I'll
I'm
go pull
proudest
that
of,
bill from the archives. If that was
yeah,
introduced,
if
I'll go
anybody
grab
wants
it.
to look up, it's AB 3052,
Okay.
called the Community
What
Residential
year?
Treatment
AB 3278?
78.
Okay.
And now the cool thing, so what it, to me, that what it put in the legislation, because I got nothing to lose, this thing's never going to pass. And there were like 90 bills all spending Governor Brown's money. And this thing went in, and it said that it was the first bill to say consumers of services should be primary members of staff, that medications could not be the first intervention. There had to be an environmental intervention that went with medications. It's not your first and only response. It mandated a vocational plan for people so we could talk. Anyway, it was my version of what I'd like to see. And what happened, obviously, that same year was Jarvis-Gann. And Proposition 13 just cut the legs out of all state government funding. Jerry Brown went from a year of mental health guy to a limited expectations governor. And all the bills got pulled. All these people would put in ways to spend, except Tom kept the community residential treatment system legislation alive. And it ended up getting out of the legislature as the only mental health bill passed out of that legislation that invested more money. It's like it got 18 million or something dollars in it because of the progressive legislators were saying, we can't abandon this commitment to mental health improvement just because of Prop 13. And this bill got out. So the reason I'm telling that story is I'm proud of it from Progress Foundation's point of view, that it got through. And it was, in fact, an opportunity for every county to get money to set up parts of a community residential treatment system. There'd have been more crisis residential programs in the state, more different versions of supported housing rather than just big housing or hotel models. But now it's history. It's almost, like a forgotten moment. But there are pieces like that in the record going through the 80s of trying to put in place what parts of that vision would look like if we did it. They're not totally without, a substantive description, but no one's ever pulled them all together.
That's fascinating. Thank you so much for that. And I'm glad the internet is forever. So this is going to be there for folks that want to know our history and understand that, it's not a moment in time. It is a continuation of history. And we have limited time. So I want to fast forward us to what is happening now. And to summarize it for folks that aren't super familiar, but anybody watching this probably is. What has happened over the last several years is we have seen a reinvigoration of involuntary interventions. Laws changed. So, the innovation now is outpatient civil commitment orders. And what that means is we're not locking you in a building, but you are nominally free, but you have to show up to court, and the court is going to order you to take your medications, and the court is going to order you to live a certain place, and the court is going to order you to go to that day treatment program or something else, and this is what we're calling care court. It's very similar, frankly. It's kind of like a different flavor. The housing piece is maybe distinct, but it's really just a kind of redux on assisted outpatient treatment that's been around for 20 plus years. So we have, this new model of institutionalization where the door in the building that you're living in may not be locked, but you are under a court order to be there. And if you defy that court order, you can end up in, the conservatorship system. And the conservatorship system is where you can be placed long-term in those locked facilities that still very much exist. So we have expansion, we have care court, we have the expansion of AOT criteria, and we had Senate Bill 43 that is just starting to be implemented that has tried to expand, go all the way back to the LPS Act and change the criteria to be more expansive even than, the late 60s. So now, if you have a mental illness or a substance use disorder and no mental illness, and you can't provide for your food, clothing, and shelter, or we think you're not attending to a serious medical condition, or you're unable to protect yourself, which is just meaningless. Now that's the front door to the institution. Now, if you meet those criteria, you can be conserved in the state of California and put in these locked programs. And in tandem with that, because those programs, okay, who's going to pay? Let's say you're conserved. You're now the problem of the county in terms of paying for your food, clothing, and shelter, your setting, where you're going to be. Does the state give the county any money for that? They do not. So, what we've seen is the poaching of funds that were supposed to be for voluntary services, and services that expand upon what Medi-Cal will do for you, what health insurance will do for you. And we're watching those they are getting sucked into this involuntary force first intervention system. The state is talking about, the state says it's making unprecedented investments in mental health. But I think we're not seeing that, right? I'm not seeing that. I'm sort of seeing the opposite, that there have been various very severe budget cuts to especially outpatient, voluntary portions of the system through various mechanisms. And so if people want to know what CalAIM payment reform is, Google it. Or if people want to know what Prop 1 is too, and the fundamental changes to the Mental Health Services Act that really make it available for the first time as a source of funding to go into these involuntary systems. I will also say, something that is happening that is new is a deeper marriage between the criminal justice system and the civil commitment system. So like something that happened not through the legislature, but after session in a sketchy way, was, okay, if you are picked up for a misdemeanor criminal charge and you are incompetent to stand trial, meaning you have a mental illness that is severe enough that you're incapable of participating in your own defense, and you're, non-restorable to being able to participate in your own defense. It used to be that a court could just drop the charge, right? It was a trespassing charge, misdemeanor trespassing. You were on somebody's lawn. The court can just drop that charge. Mm-hmm. The courts can no longer drop that charge. Now this person has to be sort of diverted out of the criminal. The civil system is an extension of the criminal system. Now you have to be in care court or AOT or conserved. And we're not going to let you out of this net. So, that's a little bit of context. But I think, your primary interest, again, is, I think, in the continuum, what we're calling the continuum of care, in the community-based services and supports that actually are upstream and prevent people from being sucked into inherently harmful interventions. And again, I think you have a unique view of this because you're more educated than I am as to many things. So if you just want to say, okay, so Prop 1 has happened. It was two things. It was, what was it, I forget the exact number. It was several $1 billion to build facilities, to build
$6.4 billion. Yeah.
$6.4 billion to build clinical treatment facilities, not what we're calling supported housing, not permanent supportive housing. Places where you go if you have a qualifying diagnosis and the primary reason that you're there is treatment of your medical condition. So there was it was a bond. Somehow they found the money without selling bonds. And there are many, many things under construction as a result of this. Now, currently. It was a continuation of an existing program called the Behavioral Health Continuum Infrastructure Grant Program. So, and actually that program got $2 billion even before this. So we're seeing massive investments in buildings. I will put it that way. Buildings of a certain character. And then on the other side of it, it was Senate Bill 326 from Senator Eggman that fundamentally changed this special source of funding for mental health services, community-based mental health services. And that's the lay of the land. Again, the big shift on the community mental health, behavioral health now services funding, the big shift is counties have to spend 30% of these funds on housing, whatever the heck that means. That money is coming directly out of services. We have a whole the actual backbone of our public mental health services are places like Progress Foundation, right? It is community-based organizations that are contracted with counties to provide these services. And, the big concern is it's those folks are going to get hit hard. And we don't know, I think the story at this point is sort of what is being created and what is being destroyed. And so I turn it over to you to talk about that, that continuum of care and where you see either opportunities or real danger ahead.
Well, as you're describing it, it passed barely. I mean, it was nip and tuck that Prop 1 almost did not pass. And because I think of what we then found, this was this past spring in the
March 5th
in the election.
Yeah.
And we're seeing the climate playing out on a federal level that was already there. So we used to have, you say we're going to, take care of the mentally ill and you're going to get a support for it, but it was nip and tuck. So I'm sort of in the middle now of reading let me say this. The way that that Prop 1 was structured, I think, and it remains, although a lot of it's been diminished, it remains an opportunity to develop programs in the community like the Progress Foundation programs. It's not excluded from that process. And of course, all of our programs we bought. They're houses in neighborhoods. We have 12 programs in San Francisco, and they're integrated in neighbors. It's the fastest way, actually, to be able to buy on behalf of either county government or a nonprofit to have a piece of property that then is dedicated to a use as a treatment program. But that's not how most counties have been looking at these funding opportunities. Number one is they can get beds real quickly through this methodology. They don't even need to build anything to start spending some of this B-chip money that you referred to as a previous round, and then Prop 1 follows that. So, it was inherently kind of a problem because, for instance, Progress Foundation was talking to a county, I won't name counties in this process, was talking to a county about possibly being a participant in their plan to implement the Prop 1 opportunities. And there was an irony which said that you had to have site control and actually be starting to work on remodeling whatever facility you might have purchased or building you were going to build by December, like a month from now. So in order to get funding from Prop 1, you already had to control the building that I thought the Prop 1 money was supposed to provide nonprofits with the capacity to buy.
That's really interesting. I did not know about that.
And guess who the only providers are? Early on in Prop 1, hospital, involuntary care in hospital was not going to be a part of it. And then it got bargained back into the deal. So the only entities that can have a piece of property ready to stand up and have running in December before you need money are institutions that have bed space. So there's going to be for-profit skilled nursing that are going to be able to get early money to expand theirs, inpatient facilities, more money to expand their inpatient facilities. But if you're trying to stand up a 10 or 12 bed treatment program in the community, that money isn't there because nonprofits don't have the money to go out and buy a $2.5 million piece of property when you haven't even learned if you're going to get the grant yet in January. So I've been questioning the timing on this. I mean, there's a pressure thing. And I'm concerned now that the process of being able to staff programs is going to be hurt by the fact that there is no staffing money in Prop 1, except for, as you're saying, this redirection of current Mental Health Services Act money into staff. So it's going to play community programs off one another. I think as it starts to, we're going to lose programs, but then get money to maybe invest in programs that may not have the most progressive view of recovery and treatment and community immersion. And so the jury will be out for a whole time. But I would say that right now, the Department of Healthcare Services, which is responsible for the implementation process under the State Health Services Agency, is that there's going to be an integrated plan required of every county that wants any and gets any of this Prop 1 money to fulfill a number of expectations of what their continuum of care looks like in the community. And there are going to be requirements that you can't just go toward institutional treatment or just toward housing, that there's going to have to be an array of programs. Apparently, I'm reading the draft regulations that are available now. Yeah. And I'm
got to go on it in a little bit.
I would like to see an aggressive thing moving toward community-based services, right. Not just 24-hour, but a whole lot of other ones.
Right. And one of our concerns and a wrinkle in all of this is that, the large expansion of involuntary interventions also require facilities that are locked to service those folks. And, it's very chaotic because on the one hand, we're bringing online all these facilities. On the other hand, the administration ran a bill through last session that says any existing unlocked infrastructure, can be converted to locked infrastructure if the county allows it. And so it's like, we kind of don't know what are you going to end up with? And I will say too, we've started, perhaps you've heard of the game 6 Degrees of Kevin Bacon. You know that? Yeah. Well, I play 3 Degrees of a Hedge Fund, and looking at even these folks that sort of masquerade as regional community-based providers doing SUD or mental health, you scratch a lot of them, and 3 Degrees. This is actually owned by a hedge fund. And this is a trend throughout healthcare, right? There's really great New York Times, NPR stories about what's going on there. And so I think, that is a major concern of ours, is that community-based programs mean that they don't have signs. They are homes in a neighborhood. They are not on the state of, they're not on the estate of Patton State Hospital. They are staffed with folks that live in this neighborhood and are part of this community that have shared lived experience. Size matters, right? Which is something because obviously you limit the number of beds, right? We don't do things on an industrial scale, and we don't do things for profit a lot of times. It's very dangerous to mix a profit motive with the ability to hold people involuntarily. And so, I think that's a big concern of ours, is like, I start looking at like, okay, who got money to build what? And let me see who you are, and then it's like, okay, there's a real concern, because I am not even seeing, some of our larger regional providers that, maybe neither one of us love their, je ne sais quoi, but they are not megacorps, ultimately owned by a hedge fund. So I think that's a real, like, it's just something we're seeing, that the smaller, people do not understand that the community-based providers have chosen to remain sort of mom and pop, so to speak, because that is essential to the service that you're providing.
Mm-hmm. Yeah, wherever there's a lot of money in a state, and California can generate a lot. So you're talking about, billions of dollars with a speeded up agenda to get things happening, to make sure there's, and this thing that you alluded to that I dealt with my whole career, which is this size issue. A couple of facts that with all of the involuntary initiatives that are there with Care Court and the redefinition of grave disability for conservatorship status and other things, is one thing to remember is San Francisco has more crisis residential treatment program beds than LA County.
Wow.
So San Francisco has 800,000 population. LA County, I don't know, what's 8 million?
Yeah, something like that.
But LA County was the basis of the political leadership that put the conservatorship expansion and care court. They and this has been a story throughout my career is that we're not holding people accountable for developing. We'll go all the way back to our first conversation in the first session, which is that we're not needing to develop a system of care that's going to be responsive as long as we can put people somewhere where the public doesn't see them. And we've never been able to defeat that. How a county like LA, they got maybe, I don't remember what the number was, 60 or $80 million to expand their crisis system of care, including residential beds. Back in Darrell Steinberg's last bill on behavioral health was to expand to fund expansion of crisis residential treatment and mobile crisis and a few other things. LA got set aside an enormous amount of money, 40 million or maybe more than that. And they were not able to stand up beds for years to do crisis residential. And why? When I would talk to them about my 4 crisis residential programs are all 12 beds or 10 beds, because that's how the treatment is effective. Their model is always, well, 4 beds, this is LA, we need 40 beds. And you say to them, a 40-bed place is an institution.
Right.
A 10-bed place is a treatment program. Why not have 10-bed programs in LA?
Right.
You got a little room down. The counties don't have that. There's no leadership from the state on an aggressive level around what counties should do. We haven't even talked about, well, this will be my most controversial statement on the thing, because I've worked with some great counties, but the biggest impediment to developing California systems of care that are responsive in the kind of ways we've just been talking about in these conversations is that we run our behavioral health system in California through the counties. And the way I like to express that to someone who doesn't understand the implication of that is that if you're having a psychiatric crisis episode at the Mexico-San Diego border, and you get on a bus, it's in San Diego County, and you're going north, depending on what county you get off that bus in, you'll have an entirely different behavioral health set of available services to you. As if people who live in San Diego need one kind of treatment system of care. People who live in San Luis Obispo need another. People who live in San Francisco. The patchwork system that we run based on county prerogatives, who get the money to do whatever they usually want to do with it. And one of the good things about Prop 1 is it's taking back some state control. I don't think their vision is progressive enough, but at least they're taking back some state control with the money. But for years, with realignment being the main problem, when realignment occurred in 1991 or 92, counties solidified their independence to do any kind of system of care they want.
So this is a controversial take.
We'll never make, huh?
I said this is a controversial take only because there is a potential, as you said, you don't feel that the state's vision is progressive enough. And I think that there is at least within our communities, maybe it should be examined, but an orthodoxy that localism is better because we just don't have any voice whatsoever at the state level. Right. And so the real impacted, the consumers, the family members, the local providers, the peers, the paraprofessionals, were like, who do you want to fight with, DHCS or the county behavioral health department? So I mean, there is, I think, in our community some favoritism of localism only because of the size of the size of the entity that you're dealing with if you want to move things in a certain direction. But it's definitely a tension. And I think I'm glad that you said what you did, because we also, folks who are using services in the system and providers, as I have a similar experience as a provider to yourself, that people don't understand how the patchwork affects accessibility to services, how disruptive it is, and especially when our folks don't have a stable living situation. I've seen them bounce from county to county. You're going to go live in this rehab setting, drug rehab setting, even though you haven't used drugs in 20 years, because you have that diagnosis. You're going to go live in Contra Costa County for 6 months. And then when your time is up there, we're going to bounce you, over to this crisis res. You're going to be there for 90 days in San Mateo County. And then you're going to go over here and you're going to go over there, and you have to change your provider every time because Medi-Cal is bifurcated. And, oh, whoops, we didn't transfer your Medi-Cal from county plan to county plan fast enough. So you don't have any medications for 2 weeks and you just ended up in the hospital. I mean, it's nuts,
Right.
So.
Yeah. The lack of coherence, to put it in the most mild form, of our system of care, it definitely results in one reality, which is driving most of these. I have an idea. We used to put people in institutions. Why don't we put them back there for their own good?
Right.
Way of thinking is there's no accountability for the fundamental idea that the individuals who are suffering on the street did not get there overnight. They got there because the county system of care was not responsive when they were reachable, when they were able to make a decision to voluntarily participate. When they saw a program, they said, I'll go there. I just don't want to go back to the emergency room. It's just amazing to me how we're in this discussion of how can you see these people on the street and not try to take care of them without the corollary, which I never heard said, even by progressive mental health leadership, that I'm very disappointed in, which is we can't just deal with the consequences of our inadequate systems. Yeah. Because we're going to create more people who are in those dire circumstances, right, unless we find out how they got there. At what point in their experience of falling apart were we not there for them that could have headed off the consequence of now they're in the street? Right. Nobody wakes up on Monday saying, I feel really mentally ill. I'm going to go lie in a street corner right now.
Exactly.
And we act like that doesn't exist, that it isn't a consequence as opposed to a condition.
Right. No, I fully and completely agree with that. And it's, and I see it also as related to the refusal to allow anyone to speak who's actually experienced this and tell you, where the quote unquote gaps in your system are. Though in my own lived experience, there is no system, there is only a gap. And if you don't fall in, something extraordinary happened. Yep. And I think, but it's based on these very, overly simplified, really ignorant and very I think that the pull of that narrative is based on the ignorance of the public and the fact that the public will believe that the only thing that has or did happen here is that someone lacks insight because of their mental illness. They're refusing treatment and they're on the streets as a consequence of that. And the fact that the public is so utterly ignorant of all things related to this community is the reason why untruths can have so much traction, I think. And, again, it would be a revolution and a revelation to go ask this guy, right? Let's ask this person who has ended up on the street, what happened here? What's the real story? How did you end up here? And it's very incoherent because on the one hand, the state is willing to say, or politicians are willing to say, we f***ed up. I am allowed to say that. I'm allowed to use the F word once. Deinstitutionalization was a policy mistake on behalf of the state, but these people who are on the streets, it's their fault, but it's also It's their fault somehow. It's like, which one is it, guys? Like, did we fail this community? Or is this community sort of like incapable of receiving the benefit of liberty and having their basic needs met?
Amen.
Well, it is 12:01, and I promise not to take your entire day. So I just want to thank you so much for being here. educating me and putting out this resource in the world that really busts a bunch of myths and hopefully allows the narrative to connect with those threads that have been there all along, from the dawn of deinstitutionalization through everything that you've said, these missed opportunities to actually build this thing we were supposed to have and we still don't have. And so I'm just incredibly grateful to you for taking your time, the time that, for this podcast, but also prepping for it with me to put this out in the world because, as they say, if you don't know history, you're doomed to repeat it.
Yes, ma'am. Okay. No, this has been wonderful. I appreciate it, Claire. We don't have enough of these discussions in the public arena around behavioral health. It's too siloed. It's too cliched. It's too unavailable for new ways of thinking. And we need to get this conversation out there because the patterns are there and the opportunities are there to change. And I hope that starts to happen. So thanks for this chance to talk with you this morning.
Absolutely. Okay. Until next time, I hope we have an occasion to do this again.
I hope so too.
All right.
I'll see you anyway, one way or the other.
Exactly.
Okay.
Okay.
Thank you, Claire.
Bye, Steve.
Bye.